webinar will be recorded, and we just wanted to let you know that the session is eligible for 1 CPD point, and if you complete both webinars, then you'll receive the 2 CPD points. At the end of the second webinar, we'll have a survey that you can fill out on both of the webinars. If you only attend one, you'll still be able to fill out that survey and receive your participant certificate. If you would like to ask questions at the end, we'll have time for a question and answer session. Please write questions in the chat box that you should see on your webinar panel. Alternatively, you also have a raise your hand icon. There should be a little hand there next to your name. You can raise your hand. I'll be able to unmute your microphone if you have one, and you can verbalise your question if you'd like to do that instead. I think that's all I need to let you know, so welcome, and I will now hand over to Gary Deed, who will be presenting our session tonight. Thank you.
Thanks, Rachel, and thank you to the ADA, and also welcome to all the people on the webinar. It's exciting use of technology, and I also acknowledge my co-presenter, Michelle Robbins, and also the expert panel that gave feedback on this particular subject. So we're going to start this particular webinar around an update on the general practice management of type 2 diabetes, and it's certainly changed from previous iterations, and if I do refer to anything here, I'm trying to also use the sections as per the web, which is racgp.org.au. If you look under the resources there, there are of course, other guidelines. The general practice management of type 2 diabetes exists under that guideline as well. So we might get started. So the objectives of tonight are actually to encourage questions and also attempt to answer those. As a bridging statement, we're trying to give an evidence of the evidence around the development of some of the targets that are embedded in these diabetes guidelines, discuss some of the international and national guidelines arising from the evidence, but then also show how they've been synthesized into the RACGP type 2 diabetes management guidelines. I do have to acknowledge that no guideline is completely always correct, and that they're a living document, and we encourage feedback, which is available through the RACGP website, or even if you write a letter care of the RACGP, at some stage that will get to me. Let's keep moving through this and get to some of the nuts and bolts. Just around how are these guidelines being written? Well, it's very important to understand that they were written primarily for general practitioners, but acknowledging in a much higher level the involvement of multidisciplinary teams, including diabetes educators amongst those principal team members, and of course other allied health members. And general practitioners all acknowledge the importance of those in chronic disease management, let alone diabetes. We did start again and try to look at recommendations which are summarised in the document, but also to clearly reference them and also grade them according to levels of evidence, using an NHMRC level of evidence where possible. Some areas are still under debate. We'll get to those in a moment. The actual document was sent out to stakeholders as part of review. One of the key stakeholders who drove a lot of the content was our newly formed RACGP National Faculty of Specific Interest Diabetes Network, and these are living and managing patients with diabetes in their everyday practice. Diabetes Australia is also co-branded on the document as previous iterations, and according to their processes, they were to send out the document for consultation to the Australian Diabetes Society and ADA for comment and input into the document. So let's keep going. Now, we all realise that the highest level of evidence, according to both guidelines and also clinical practice guidelines is recognised as the NHMRC. The diabetes arena, the NHMRC guidelines exist from 2009, and therefore it's not saying that the information or data in those guidelines is irrelevant today. In fact, much of the data still has some relevance to clinical practice. However, some of the tools we're using for management have progressed beyond that, and so you'll see that our guidelines go beyond some of the scope of the NHMRC, but try to use the grading of evidence like that. We acknowledge the Australian Diabetes Society have other guidelines and discussion papers such as the hemoglobin A1C targets from 2009, and very importantly that type 1 diabetes was not addressed principally in this document because there's a very recent update on the NHMRC type 1 diabetes guidelines from 2013. And, you know, I'm talking to probably the converted, but why do we need guidelines? Guidelines aren't a paternalistic way of governing how we should practice. They're actually just to help assist the dilution and then also refinement of the evidence so that people in clinical practice don't have to then do all of the searching over whole bounds of information and sort of bring that all into one particular way to help you individually manage your patients. Thanks, Rachel. Might go to the next slide. So this is the cover. Some of you might have seen the hard cover, although I think there is a limited print run on the hard cover at the present time. And what we decided was, in fact, as per other RACGP guidelines, that in fact a living copy would exist on the RACGP website in modular form, which allows us to update the document if there are significant environmental and clinical practice changes in the life of this document. So once it's printed, unfortunately there are some printing errors in the document. I could go into some detail around those if people wish. One particular error is around the flowchart of diagnosis of diabetes using fasting glucose, where less than equal to 7 has come out as just a less than 7 millimole per mole. But also remember, even of the last week, we've seen a change in the government allocation of hemoglobin A1C as being able to be funded as a diagnostic tool for all types of diabetes at least once per annum in the diagnosis of diabetes. So that's how it changes, and we may have to update that section in the next few months. Thanks, Rachel. The sweet pea on the cover is just a play on words, basically. It is a sweet pea plant. Some people have asked us that. I do have to emphasise there is a very strong focus, and the RACGP has driven these guidelines from the ground up. In the past, they've been driven by Diabetes Australia. I don't think that's a bad thing to take the clinician side and RACGP depth to drive the development at this time. There is, as I said, a multidisciplinary focus. I think we know that, and all recommendations do reappear in Appendix A and are referenced. Thanks, Rachel. One of the things, and you all would recognise this from the American Diabetes Society Association and the European Society for Study of Diabetes management guidelines. And this is about novel maybe to many GPs is the understanding the individualisation of approach to managing diabetes, and trying to start that conversation with general practices that you're looking at the patient sitting in front of you who has more than just a glycemic illness. They actually have lives, and you have to incorporate your thinking on how you're going to manage those patients and around not only glycemic targets but other targets by addressing some of those factors which are clearly outlined there. And, you know, some of them will affect whether the targets are less stringent or more stringent. Thank you. Now, and this target summary is about what target should we aim for. And I think that's a very important document, because if we're going to use targets and incorporate individualisation, you can see some of the, it's a bit wordy there. Some general practitioners were concerned that, that maybe these words were too loose, for instance, around hemoglobin A1C. Why can't it be just a solitary number? But we're trying to emphasise that not only in diabetes, but across many chronic diseases, it's about the individual in front of you, and that you have to use smarter tools to actually assess what do you do in that patient. For instance, the hemoglobin A1C, we're giving a range. We do say on average about 53 millimole per mole, but there is a range, and that range should be adapted if you look deeper into the document around those issues. Again, around lipids, we all know this is a moving target, and even blood pressure. And we're saying that if you are going to use pharmacotherapy, it should be dependent on the assessment of absolute risk. That is, if it's for primary prevention, look at absolute risk, not the exact numbers, because it depends on the patient's multiple risks adding up to a treatable target. So yes, we've given some general targets there, but around blood pressure, for instance, 130 on 80 is even now under debate, and that issue will be mentioned later. Other things though, I mean, cigarette smoking, I don't think anyone will debate that's a pretty absolute target, as is alcohol consumption as well. Thanks, Rachel. So we might go to the next slide.
Did you want the medication algorithm or the next one?
Just the next slide, whatever the slide is there, thanks. Is it working or?
Might not see it.
Oh, sorry, I'll go to I've got a slow, it might be my machine going very slow. Sorry about that.
That's okay.
So the treatment algorithm where there's a big red cross is the slide that I have on my machine is the next slide. And that actually comes from that NHMRC guideline as well. And it shows that that actually is not really current or up to date in the Australian treatment algorithms, because in fact uses a very old stepwise approach to management, but incorporates agents and misses agents that aren't currently widely used in Australia. And I think that's a very significant change that we've moved away from. And talking to people who've worked very hard on that particular algorithm, they would say it was one of the only aspects of the NHMRC guideline that wasn't properly evidence-based. So in our guidelines, we've gone to a different model, and I hope, Rachel, I can't see these moving on my machine, but I hope...
No, that's okay. I was just going to explain. So this is supposed to have a big red cross through it, this treatment algorithm. So it's the previous one.
Okay, good.
So we'll move on now.
Yes. So I'm going now to my next slide, which is the, the review of the treatment algorithm, which is embedded in these new guidelines. And again, I warn you that some of this may actually change in the life of this printed document, but some of it won't. One of the things that won't change is that the fact that lifestyle and physical activity is the underpinning of all approaches to diabetes of type 2, where appropriate, and it should be individualised, of course. And that metformin still remains as one of the principal choices for patients with type 2 diabetes as an initial choice if tolerated. We did put in sulfonylureas there, but I think it's very important that if persons are intolerant of metformin, but the second line options are now flattened down to an individualised approach, and people should be encouraged in their clinical practice, including GPs, to look at the individual patient and look at different medication classes and try to use those to the best of their ability in applying that to the individual patient. Why we try to get away from a PBS-driven algorithm is because the PBS wording changes too frequently, and in fact we wanted to put some evidence that each of those agents have equal efficacy across a range of appropriate clinical targets. So for instance, now it's quite appropriate, and you notice the PBAC has allowed DPP-4 inhibitors to be considered almost at the same level, not almost, the same level of sulfonylureas. And yes, there are cost implications to that, but there are patient-led clear reasons why you might choose that class compared to a sulfonylurea. And we noted also we embedded the SGLT2s also as an appropriate class to consider second line. And GLP-1 agonists. I mean, this isn't a new class, and I think the uptake of that class needs to be encouraged in appropriate individualised management. We didn't want to ignore sulfonylureas or the TZDs or even acarbose if it's appropriate, because each class should be considered on their merit in the individual patient if efficacy was considered appropriate, including insulin if it was appropriate in the correct patient. We outlined, though, what was very clear, what we also outlined was that there's something now we encourage people to understand which is called a stop rule. The stop rule in some circles is perceived as that you must stop medication if the medication is not working, and that certainly wasn't what the RACGP and working group decided was appropriate. The stopping rule, I think, is a very important understanding that you should reevaluate patients at a maximum of 6 months at any one level of medication intervention. For instance, certainly even with lifestyle intervention, one would hopefully be trying to proceed through management and early control of diabetes well before 6 months. But we put an outer limit, especially when medication was introduced, at 6 months maximum to address patient and also clinician inertia, but also to address re-evaluation of a patient on a clinical basis, so that if there are things that might be missed, for instance, it may be the fact the patient isn't actually taking the current medication. So why would you add another medication if the patient isn't understanding in the health literacy sense the need for adherence to that sort of advice? You know, things like occult infections, for instance, or other comorbidities are very important to re-evaluate. If they are re-evaluated, the stop rule applies then that you move forward, certainly within 3 months or within 6 months as a maximum. Right, so I'm just going to go to my next slide, and maybe hopefully everyone else can see these slides as I'm seeing them as well. So can I summarise what I've just said too? And again, the slide title is Medication Changes. This is an emphasis on the individualisation of choices, and it's about what really underpins a lot of these guidelines is the evidence is that we must independently use our skill and judgment and professional advice to be relevant to the particular circumstance of the patient. And individualisation of medication is no different to that. Very clearly, and I emphasise again the elevation of choices and second-tier medication choices as an add-on to metformin, and you know, listing DPP-4 inhibitors, SGLT2 inhibitors, GLP-1s at the same level as previously considered sulfonylureas. And I have gone over the stop rule very clearly. So let's move on from that to something around some of the other changes in the guidelines. And for some reason, some people believe that the changes around self-monitoring of blood glucose is a little bit controversial, but in fact, it's quite clear that from our guidelines, if you read the guidelines correctly, we're saying that self-monitoring of blood glucose is recommended in the process where changes in treatment, lifestyle, or other conditions requires data on glycemic patterns, which is in fact a good evidence-based, broad recommendation. And also with patients where there are risks of hypoglycemia and the need to track those glycemic patterns when hemoglobin A1C may not be reliable. And that may be a hemoglobinopathy, for instance, and a recent transfusion of patients are clear examples which are embedded in these guidelines. The other thing, though, is also the fact that illness and sick day management, which is now a new section in these guidelines, has been clearly articulated as well. So I think that's based around some clear evidence that self-monitoring has some usefulness. But then we also went further and say just the bland routine self-monitoring in low-risk patients is not recommended. When we say that, it doesn't take away from what was written above. It's just saying that for GPs, unless you've got some usefulness in the data on glycemic patterns, for instance, that is that the hemoglobin A1C may take 3 months to review and show a change. If you need to find some difference in patterns, yes, you can do the self-monitoring of patients. But it is not recommended in low-risk patients where that is not an issue. For instance, on monotherapy on metformin, for instance, or other combinations with metformin with low risk of hypoglycemia. However, it may be appropriate if it's about a lifestyle, education, and management appropriate to that patient. But that's not a routine self-monitoring. That's using it in an appropriate clinical setting. And it needs to, as it says, the method and frequency needs to reflect individual circumstances and therapeutic aims where the health professional will have the knowledge, skills, and willingness to incorporate that. So I think that's quite a useful update, and around the evidence that some quite high-level clinical reviews and meta-analyses have shown that we do have to be concerned about patient welfare and quality of life issues when we institute medical interventions that may not actually change our therapeutic outcomes, and the patient may not understand and apply some of those therapeutic aims. Other updates around sick day management, for instance, and I acknowledge that there's been an update, and ADA were used as certainly agents in driving some of the potential around sick day management and the usefulness in clinical practice. So I know there's been an update even since the production of these guidelines. So any further update will be incorporated in our ongoing documentation as well. Other changes are end-of-life care, which is not a significant aspect of clinical care. And this is a completely new section, which is now section 15 in the document, which will assist people to understand some of the issues that are need to be applied to that particular clinical process. We've highly emphasized, I've already talked about risk assessment tools around some of the targets, but I've emphasized also about multiple and comorbidities within the document, and there's quite an in-depth section, and this is also applies in section 12 around the idea that diabetes doesn't exist in a bubble, and it's certainly unique about the glycemic implications for long-term health outcomes. But we are treating people in the real world where cardiovascular disease, depression, for instance, amongst some significant issues need to be addressed. Clinical governance is also covered, and I really should have started with that, is that good clinical governance underpins the structure and the systems of care that help all patients with diabetes as well. So, and that's about putting in systems of recall and quality processes, using allied health professionals, appropriate use of practice nurse within skill attainment levels, and certainly the diabetes educators and diabetes services that are available for patients. Also the changes, as I said, about risk assessment tools, not just for the prevention of and detection of early diabetes such as the osteoporosis risk, but also just around the application of medication interventions such as in lipid disorders as well. In appendices, there are many appendices that have been applied to the document. One, I mean, the OSD risk is, of course, Appendix C. Care plans, and we actually gave you some samples of some care plans and GP management plans, and also a patient care plan that again, is there for use where appropriate, but also to guide people who might need a tool in their clinical practice. There are, in Appendix I, for instance, now some examples of insulin initiation and titration, both the basal, basal plus, and premixed insulins, which has never appeared in any prior documentation. These, I just have to emphasize again around some controversies, these are examples that are there to assist rather than absolute, you must follow this to the T, for instance. Glycemic emergencies in Appendix J still exist as well, but I really want to move on to a very important aspect of the appendices, but I don't want to say they're just appendices. They're actually now, we've fought very hard and fast to incorporate Appendix E and Appendix F, which are the psychological assessment tools for depression and distress in clinical practice. And this was put in because of our passionate acknowledgement that people with diabetes live lives of which diabetes can impact in dramatic and sometimes poorly assessed ways. And the way to assess that is actually to encourage the use of evidence-based tools, such as the PAID tool and the PHQ-2 tool. When I say evidence-based, the use of the tools and then the evidence of the intervention creating changes in long-term outcomes needs further research. But the research is very clear that people with diabetes do have distress and depression. It's very clear that health professionals need to stand up to the mark and actually engage in the conversation and assessment of these patients. So I'll just quickly go through the PAID tool. So this is a little bit more of a complex questionnaire, and so the patient would read the questions carefully and then mark the questions. I think there's 19 questions there, of which they have to then address, is this not a problem, a minor problem, moderate problem, somewhat serious problem, or a serious problem in their own terms. And it goes across a wide range of lifestyle, diabetes-specific issues. Actually, there's 20 questions. So, and individual items, anything greater than a 3, which is somewhat serious problem, should be discussed with the patient. So each line individually, if it's at a 3 on that line, you should discuss it. But then the sum total of the score, when added up, and then the score is marked out of 100, and then multiplied by 1.25, and the higher the score indicates the higher levels of diabetes distress. Take-home messages, scores over 40 indicate severe diabetes distress and really require being addressed on a clinical level with the patient in front of you. The PHQ tool is a much much more compact tool. In fact, it's only 2 questions, and this was, embedded both tools because we wanted general practitioners not to believe that it was an onerous task, and that this tool has some validity in the clinical management of psychological distress in patients with diabetes. And if scored correctly, anything over 3 requires further assessment using a diagnostic tool for depression that's appropriate to the patient and their literacy state. So both tools can be used by diabetes educators, and feedback to general practitioners is very useful. If you notice a patient hasn't had those depression or distress scores answered, it certainly is within the bounds of your clinical practice to administer those, and certainly emphasize to the GP that where there are positive results. The other thing then, just as we get close to the end of my talking, there are issues under debate which are in section 16. And I mean, will I be able to completely can I completely cover all of these? It's going to be, that would be a big issue. But one of the biggest issues in the documentation, is issue under debate, is that the diagnostic criteria of gestational diabetes management. From our perspective, there are very clear reasons why we felt that we didn't want to encompass those new ADIPS guidelines at this point in time. That may change. As I said, this is a living document. And I noticed in many health jurisdictions, for instance in Brisbane, one half of the city is using the new criterion and the other half of the city on the other side of the river don't. So I mean, there's still room for development and agreement around those. And there's further issues around the follow-up of patients with type 2, with gestational diabetes mellitus, etc. The diabetes guidelines do acknowledge the debate and the current clinical debate around blood pressure targets in type 2 diabetes management. And I think that, internationally there is a push to increase the targets out to 140 on 90. But there's still some evidence in patients with diabetes and with renal disease that 130 on 80 was a reasonable general target, but incorporating an individualized approach, acknowledging that lowering targets increases the risk of falls and stroke in some high-risk subpopulations as well. One of the other things is the target A1C. I did mention the ADS 2009 working paper and published guidelines around those. The RACGP decided to limit high-level evidence of the guidelines to A1C of between 6.5 or 48 millimole per mole to 7% as a general target, or 53 millimole per mole, acknowledging there is a breadth of individualized approach. The other thing was around, the idea that does an EGFR of 45 to 60 have any clinical consequence when, that could be an ongoing debate. And also, again, as I acknowledge the use of the PAID tool and PHQ tool does need linkage to long-term improved outcomes and complication reduction. So finally, I'll just say that feedback is encouraged again by the RACGP website or personal correspondence. I'm happy to receive that. I've already received much correspondence around things, and we're quite happy to respond to that in appropriate channels as well. But Rachel, I might leave it at that and maybe seek some input to some questions.
Thank you, Gary. That was great. So we'll just get the panelists to log back in and see if the audience has any questions for you guys. That would be great. Just going to. So again, just let you know that that members are eligible to claim CPD points for the webinar series. The surveys will be sent out at the end of next week's webinar, so you'll still be able to participate if you only attend this webinar, but it won't actually be sent out till next week. And also to acknowledge our sponsorship, obviously, from AstraZeneca. Without them, this webinar series wouldn't have been possible. So please post your questions. We've got a bit of time. We will try and wrap it up by 7, but we'll see how we go. So I have one question here. Targets for self-monitoring blood glucose of 6 to 8 millimoles per litre fasting and 6 to 10 millimoles per litre postprandial are obviously general and mindful of prevention of unnecessary hypoglycemia and need to be individualised. Can you comment on the advice you would give to clients when adjusting them? Jayne, I might hand that question to you.
Oh, thank you. I guess personally I would be asking the person a lot of questions around what they want to achieve from doing the blood glucose monitoring, what happens in their lifestyle, what kind of diabetes they have, what treatment they're on. I guess one of the challenges with the guidelines, as Gary said, was that frequently we have GPs and diabetes educators, a range of people looking at these guidelines, and they don't read the whole document. And so when you read the initial summary of the targets, it's got some additional information there, but putting some of that into practice, my concern is that we may well have that same person with diabetes being suggested different things depending on if they're advised by the GP or the diabetes educator. So I guess it would have been, what I hope it doesn't do is create confusion between health professionals. So, you know, a good assessment is needed, and also finding out, making sure that the person knows what the numbers are, what they mean, getting accurate results, know what to do with it, know what their targets are, same with the health professional. Now, if you've got that in place, you can frequently do structured blood glucose monitoring in a way that actually decreases blood testing. So I get a lot of people to do the initial 3-day 7-point testing before and 2 hours post each meal and before bed. That usually gives me a really good idea of where things are at. It certainly helps structure medication review as well, and then modify from there, giving people a break when their levels are going well.
So do either of the Gary or Gary want to comment on how you might individualise if you're trying to get closer targets or more stringent targets for an individual, even though the guidelines say 6 to 10 postprandial? How would you advise around that if you're looking to get them a bit tighter than that?
Oh, so it's Gary D here. I think I'll just quickly explain why those targets are grade C NHMRC level, and we currently don't have any other better gradation of setting of targets of self-monitoring blood glucose in the Australian environment. If anyone could provide a higher grade than that, I'd like to see the document so we can update this. Number one is also that the fact that those were set by NHMRC because of the errors in self-blood glucose monitoring, potentially through not only the equipment but also how the monitoring was done. So we generally, and this is a general statement, that a 10% error can occur at a self-monitoring of blood glucose level on even the best equipment and technology currently. And we all acknowledge that, of course, the self-monitoring measures capillary glucose, and it has a lag time and, as I said, a 10% error rate with the equivalent venous glucose level. So if you set a level of fasting, for instance, at 4 to 6, for instance, it is potential that with self-monitoring of blood glucose, some of those patients may be having hypoglycemic attacks to achieve your imposed target of 4 to 6. Remember that a 10% error rate is there. So that's why we erred on the level of the NHMRC grade C 6 to 8 pre-prandial and fasting, and 6 to 10 post-prandial. And there is no evidence, if you then use a clear hemoglobin A1C calculator from achieving those levels, you actually will still achieve the hemoglobin A1C targets that are set also in this document. And again, anyone who can give me a high-level evidence that that can't be achieved by these particular levels, I'd love to see that.
Okay,
so
thank you.
Just to add, sorry, Gary Kilov here, just to add, without reiterating the importance of individualising care, but remember that glycemia, whilst important, is only part of what we're treating, and sometimes there's better bang for your buck in looking at tightening blood pressure control, lipid control, in order to achieve the better long-term outcomes. And again, you know, if I have a patient who's on metformin or metformin and a DPP-4 inhibitor, and they're achieving fasting blood glucose of 4.55, I'm much less anxious about that than if I have a patient who's on insulin. And now with the advancement of technology, the availability of continuous glucose monitoring, which I'm sure you're all very familiar with, you can get a much clearer idea of what's happening both in terms of response to treatment, but also, equally important, the question of safety. And I think Gary was alluding to the fact that, as we get lower, and again, you all know this, as we get lower, the risk of hypoglycemia increases, and it is a law of diminishing returns. So, a drop from an A1C of 10 to an A1C of 9, you get a bigger bang for your buck than a drop from 7 to 6. So it is finessing this and adding the art of medicine to the science. But we almost subliminally, with any intervention, so it's not only therapeutic intervention, but it's investigations as well, balance risk versus benefit. And if we are putting our targets too low, we start significantly increasing risk with marginal increasing benefit. So I would say that for most of my patients, I'd be very comfortable with a fasting blood glucose around 6. But again, it would depend on the downside risk for that particular individual.
Okay, that's great. The next question is from Victoria. I might direct this to Gary Deed because it's about the guidelines. Could you comment on the guidelines for alcohol? There is no recommendation for 2 alcohol-free days per week in the publication.
Yeah, so I think, again, this illustrates Jayne's point that unless you read the detail, you might miss that. And we're saying, we're trying to refer people back to the alcohol guidelines and the recommendations. So, the 2 standard drinks per day. And if that's not embedded in there, it certainly would be an oversight. But we're saying that certainly, as per the Australian guidelines, 2 alcohol-free days would be appropriate. To patients with diabetes, it's exactly the same. What we're trying to do is not give people with diabetes an ability to get confused that they're different to other people out there, and the evidence is clear that if we stick to those alcohol guidelines, they will be as protected as other patients in the population.
Okay, great. Next question, how do you go about educating GPs to look at alternative OHAs rather than relying on metformin and sulfonylureas?
Are you asking me?
I'll open it to whoever would like to answer. That's a tricky one.
Do you want me to give you some
input from an educator perspective?
Yeah, because I get this frequently. What I will do is, in my letters back to the GP, after I've discussed with the person with diabetes what might suit their blood glucose profile as well as lifestyle, I'll make a recommendation as to what they could consider, and I give them the rationale for it as well. And I guess this is where doing the profile across the day helps you pick up if it's a postprandial issue or fasting or in response to food. So you can actually customise much better if you've got numbers that you can also present to the GP with an explanation of why you're making that choice. I find that frequently works, not always, but frequently.
I think, Jayne, you raised a very important point, that it is about that communication and collaboration between professionals. And if you develop a good relationship with the referring GP, I think most of you would find that GPs would be very receptive to recommendations and suggestions. Gary Deed and myself and many other members of the specific interest group do lots and lots of peer-to-peer education. We try and upskill our GP colleagues, but this is in no way either to excuse or allow GPs off the hook, but GPs are struggling to keep up to date in every area and every sphere. An example is, not only this exponential rise in diabetes medications, but if you think about, for example, cardiovascular medications, there are 3 new novel oral anticoagulants that have joined. There are new antiplatelet agents. we're going to have something like 18 different inhalers for COPD, and the list goes on and on. So it is quite onerous to try and keep up to date with all of this, and you guys are very expert. If you do have that relationship with your GP, I think you'll find them very receptive. So don't be afraid to do what Jayne suggested, and that is making a suggestion, making a recommendation, providing the rationale, and you will be doing two things. You'll be helping the patient achieve targets, and you'll also be upskilling the GP.
That's great. I might put the next question. Oh, sorry, Jayne.
Can I just add to that I'd like to say that it works every time I do that. I've also had the opposite experience where you do that in a respectful manner and then you're no longer referred to by that GP. So you just have to put it out there, and I guess the value of it is the education. I guess that's where it would be great to see greater utilisation by GPs of us as diabetes educators, especially now that we are within general practice. There's a bit of a myth that we're not able to take clients because we've got long waiting lists, and not all of us have. And so, you know, when you get that doctor and diabetes educator working together and with a person that's included, that's when the magic happens, when you put the blood glucose monitoring in as well.
Yeah. Jayne, just in response to the negative reaction from GPs, that's very, very disappointing, because I think certainly most quality practice acknowledges without question that you know, general practice cannot be done without multidisciplinary support. And I mentioned that what is important is the relationship, and sometimes you might consider even meeting face-to-face with a referring GP, and it makes such a big difference when there's a person involved rather than just a letterhead. You can sometimes turn people around quite effectively.
If you can get in to see them.
Yes.
Okay, next question. Thanks, guys. Next question to Gary D, because it's about the guidelines again. So and understanding the medication algorithm. So can a DPP4 be used next if metformin is not tolerated?
Absolutely. In the PBS, for instance, you can use a DPP4 with the sulfonylurea. I think that's the question is that they are for dual therapy according to the PBS. They're not currently PBS listed as monotherapy. So I hope I'm answering your question. Yes, you can, and those changes occurred both in December and March and April of this past year. So that whole idea of this dual therapy of the DPP4 as a valid, evidence-based, highly efficacious therapy in the appropriate patient has been pretty well established, and the benchmark has been set by the PBS. So yes, you can, but can I remind you that also that you can use other agents, oral agents or injectable agents, appropriate to that patient, as is in second line and third line. You just have to read the PBS criteria. So there's a bit of background noise there. I'm sorry about that. It's not from my end, but there appears to there will be some changes in the PBS even in the December iterations, allowing possibly earlier use of some of the other oral agents. So, you know, watch this space. So in the time that these guidelines were released, that's why we didn't want to put a PBS box within them. And so we just looked at the evidence. The evidence is you can use metformin or sulfonylurea with some of those dual agents. The safest combination is a metformin and another oral agent if we're looking at hypoglycemia and weight gain risks, and possibly metformin with injectable where possible on injectable GLP-1 where possible under the PBS. I'm sorry for the background noise. I just think there's some background noise there. Sorry, Rachel.
No, that's okay. There's a bit of background. I'm not sure where it's coming from. So sorry, guys, if you can hear that. Next question, is there an association with sitagliptin and tachycardia? So Gary Kilov, do you want to start with that?
So relationship between
sitagliptin and tachycardia.
My understanding is the association has been more consistent with GLP-1 agonists rather than DPP-4 inhibitors. I think the cardiovascular issues around DPP-4s have been a signal around heart failure, although there's no increased mortality. But I think the tachycardia issue is more a GLP-1 issue.
So certainly that relates to multiple factors, as Gary did here, including minor changes in blood pressure, which occur also with the GLP-1 in a positive way, by the way. So I don't think, when we're talking about individual sort of issues like this, there's never been any clinically meaningful outcome from a minor change in the increase in pulse rate, not only with sitagliptin, but GLP-1s and other DPP-4s. So I don't think it's a clinically meaningful issue.
Okay, next question. We're nearly there. Is declining renal function a reason to look for alternatives to ongoing sulfonylurea use?
Absolutely. You know, I mean, remember when we talk about declining renal function, it's a person who has diabetes who has declining renal function. So, you know, you have to look at the person in front of you, not just the test result, number one. And, you know, is that person elderly and have they had long-standing diabetes? And what other medications are they on? Will colour your choice of what you do. Metformin, of course, is the elephant in the room. I mean, already, you know, if we're getting under an EGFR of certainly under 45, one would be looking at dose reduction. 30 to 30, one would be looking at a clear need to revise what we're doing with that. And then, you know, amongst the other classes, you'll have to choose which agent is most appropriate in that patient, what dose. And most of the DPP-4s now, you can reduce the dose so they can still be used in an ongoing fashion. The SGLT2 class, because of the unique renal action, certainly might need to be revised under an EGFR of 60, certainly under 45 for some agents as well. So it's an important question, but remember hypoglycemia risk is higher if you're using sulfonylureas in that group. So when you choose an agent, I mean, with renal function, you're thinking about metformin, what do I do at the dose, is it appropriate, and what is the best other agent, acknowledging that people with renal dysfunction have a higher cardiovascular risk, higher rates of hypoglycemia, and all the sequelae of that. Therefore, if I choose an agent, I'm going to choose an agent which gives us the biggest bang for buck without increasing risks and side effects.
Nothing to add to that, Gary Kilov?
Yeah, just very briefly, we would choose, if you were to use a sulfonylurea, we would choose a shorter acting one, an agent that didn't have active metabolites. So it would probably be glycoside, and it would probably be in a lower dose. And I think there is a move to, just as we've seen with antihypertensive medications, rather than ramping up one agent to its maximum dose and then adding another, using a combination of submaximal doses of medications and getting the better outcomes with fewer adverse effects. But as Gary did mention, the issue around renal function, declining renal function, is that people with renal impairment are really more fragile, if you like. They are at greater risk of a whole range of things, and so their ability to both withstand hypoglycemia and respond to hypoglycemia is diminished. Their ability to excrete renal metabolites is declined, so that you can get accumulation of these agents, and that's why you don't want any sulfonylureas with active metabolites. But as renal function declines, your choices do decline as well. and you may find that if you do need an agent, if you need something beyond your reduced dose of metformin and the DPP-4, you may well be looking at insulin as an alternative.
Okay, I've only got 2 more questions, so we'll finish close to time. The next one's probably for Gary Deed again. RACGP are the only ones holding out on the new GDM criteria versus WHO, ADIPS, RANZCOG. Why is this?
I can clear. I don't think you've incorporated ADS, have not come out with a clear high level. I mean, even though ADIPS is considered a sub-committee, the ADS Council have not come out with the blanket statement also supporting it, number one. Number two is that the MJA had a very clear, well-written debate around the issue by leading endocrinologists and diabetologists in this country who questioned the validity of and outcomes drawn from the new ADIPS guidelines. And in fact, if you read the ADIPS guidelines, they acknowledge that by setting the new target levels, those levels are not the levels that are associated with clinical negative outcomes. It's an assumption they've embedded into them. So, I mean, I think you know, at the end of the day, it's a debate that needs to be ongoing. We're not the only ones that are holding out. I mean, if you look internationally, there are also significant bodies of experts who consider that these guidelines need a bit more clear evidence-based linkage to severe outcomes. If you stick with the current GDM guidelines, you are still preventing harm and distress in both the mother and the infant, and that they are clearly evidence-based. Whether the new guidelines will shift that to an improved outcome for all mothers and all people with all offspring, that's, I believe, still waiting to be proven.
Okay, and I've got one last question I might throw to Gary Kilov first, and then if you want to add anything, Jayne or Gary Deed, you can. Do you think that GLP-1 can eventually be used with insulin?
So GLP-1s and basal insulin are really a great combination because you have the synergies where you have a basal insulin looking after the fasting glucose very nicely, and GLP-1s, particularly the shorter acting ones, being very effective for postprandial glucose rises. And you also have the GLP-1 effect mitigating any weight gain associated with insulin usage. So there are quite a number of trials utilizing a combination of different basal insulins and GLP-1s, and they universally show good outcomes. And in fact, there are products, I think, in development within one delivery device where there will be GLP-1s and basal insulins commingled. So these agents have been shown to be very, very effective. The question is, of course, whether they will get TGA approval and eventually PBS listing. And that's, of course, anybody's guess. But in terms of both the rationale for use and the evidence supporting them, this is a great combination of medications.
Yes, I would agree with what Gary's saying, and I guess it would be great to have like an overlap thing for the guideline advice that shows the PBS listing of the current recommendations, because it would certainly guide people, I think, a little bit more in their decision making when they start looking at what's being suggested. Certainly, you know, as things go forward, it will be whatever we as taxpayers and our government decide that they want to pay for. So, you know, what will limit some of this will be, you know, the financial realities. One of the, I guess, challenges with the guidelines is that because we're now looking at individual management, we're starting to think of all these new opportunities, and some people are likely to, pay for a private script for some of these opportunities already. But you actually have to be even more skilled to individualise. So it's a bit of a challenge if we can get diabetes educators working closely with GPs and practice nurses and not have, one think they can do it all, then you will get more opportunities, I think, for implementing these sorts of new products in the future.
I just, sorry, and Rachel, I know the time's there. In the iteration of these guidelines, the PBS has changed and will change numerous times. So it's a matter of whether we use something that's already old by the time we publish it, number one. Number two is the GLP-1s, just to reiterate what Gary said, have a great ability also to limit the dosages needed for insulin usage. So they're called insulin sparing. And of course, it's little only the whole adage around weight and weight management is not insignificant in its ability to limit that. But also the last thing I'll say is there's very clear emerging evidence that if you want people to maintain weight and certainly not gain weight, appetite reduction is a minimum. And the GLP-1s, through their effect as a side effect, do that. So they're broadening the whole aspect of managing diabetes by synergizing with existing medications such as insulin, by providing additional medically appropriate therapy that addresses maybe not only weight gain, but also helping weight loss, but also maintaining weight by appetite suppression. So they've got an expanding and a continuing role in any future management of type 2 diabetes.
Thank you very much. That will conclude our session tonight. Sorry, was there anything else?
Thank you.
No, I just want to say thank you, Rachel, and the ADA, and I think the guidelines embed the role of well-placed and trusted CD in the management of diabetes in general practice.
Yeah, thank you to the panel members, so Jayne Lehmann, Dr. Gary Kilov and Dr. Gary Deed for doing the presentation this evening. It was excellent, and I hope that the audience got a lot out of it. I also hope that you will attend next week's webinar in this same series where Michelle Robbins will be presenting, I guess, more on the side of a diabetes educator, but we will have the panellists back again to answer any questions that might have come up from this webinar and also from the one next Thursday. So thank you very much, and thank you once again to AstraZeneca for sponsoring this series. I hope you all have a good night. Thank you.
Good night.
Thank you and good night.
Good night.